Great. Good morning, and thank you for having me. So neurotrophic keratitis is a rare condition, but it can be quite challenging to treat. It occurs when there's damage to the trigeminal nerve anywhere in the pathway. So this can occur in the brainstem from a stroke, for example, at the trigeminal nerve ganglia from an aneurysm or acoustic neuroma. It can be from a damage to ciliary nerves, from an orbital tumor or orbital surgery, direct damage to ocular nerves from PRP or TCP, and then probably the most common way that we see this is from corneal nerve damage from infection, such as herpetic keratitis, chemical injury, or surgery, such as penetrating keratoplasty, or topical medication use chronically. Trigeminal nerve damage leads to decreased corneal nerve health, loss of protective reflexes, and loss of trophic neuromodulators that maintain the health of the epithelium. This can result in epithelial breakdown and impairment of wound healing. This is a 79-year-old woman that I have taken care of with a history of diabetes, which can also lead to corneal nerve damage, and glaucoma. She'd had an OMID valve treatment and was doing fine, but then underwent micropulse TCP for improved IOP control. She subsequently developed a neurotrophic ulcer that you can see here, and we believe that this is due to thermal injury to the perilimbal nerve plexus. So in this talk, I'm going to discuss my approach to caring for these patients with neurotrophic ulcers, neurotrophic keratitis, and this slide really provides the outline for that. Essentially, the treatment depends on the stage of disease or the severity of disease. I will briefly touch on a lot of these treatments, but subsequent speakers will discuss them in much more detail. So in stage 1 here, you can see at the top, it usually presents with an epitheliopathy. You can get hypertrophic epithelium, and sometimes it can even mimic an HSC keratitis, for example. In this stage, I really focus on treating concurrent ocular surface disease, such as blepharitis, aqueous deficiency, exposure keratopathy. I will also switch patients to preservative-free drops. A lot of these patients have been on glaucoma drops with preservatives multiple times per day, and that's really contributing to the epitheliopathy that we see here. I also ensure proper drop administration. I observe patients giving themselves drops because the corneal nerves are not normal, and patients may not realize that they're actually touching the surface of their eye. For that reason, I also minimize artificial tear use unless the patient has true aqueous deficiency, because every time the patient administers a drop, there is a chance that they could injure themselves. In stage 2, we have chronic epithelial defects, and in these cases, I really increase the treatment. I do everything that I do for stage 1, but in addition, I will introduce Serum Tears, sometimes do amniotic membrane grafts, lateral Pterosaur Fee, or introduce Scleral Lenses. And in stage 3 here, you can see at the bottom, this patient has an ulcer. They also have a small hypopion, which can occur in neurotrophic keratitis. And in the past, we didn't have much to offer these patients. We could do a conjunctival flap to cover the cornea and promote healing. We could glue the cornea or perform a patch graft if there was a perforation. But now we have novel treatments, including topical oxervate or sinogermin, and corneal neurotization. So there have been some exciting innovations in this area. Serum Tears are made from patients' blood serum, and they contain important growth factors and nutrients that are normally found in healthy tears. They've been shown to improve dry eye symptoms and signs and improve healing of chronic epithelial defects. At Kaiser, we use Vital Tears, which is an eye bank that's become specialized in making Serum Tears, and we have a really streamlined process. So once the patient gets their blood drawn, the serum is sent to Vital Tears and gets shipped to the patient within 24 hours, and they get about a 6-month supply that they can put in their freezer and then defrost as needed. Amniotic membrane has been shown to have anti-inflammatory, anti-fibrotic, anti-angiogenic, and antimicrobial properties. It also provides an excellent substrate for the growth and migration of epithelial cells of the cornea and conjunctiva. Typically, I will use cryopreserved amniotic membrane and suture it in place with a perilimbal purse string suture in the operating room. However, in the last few years, I've discovered AmnioDisc from Katina and had really good success with it. It's quite easy to use. So you take the dried membrane, put it on the ocular surface just in the clinic, and then place a contact lens over that. And I have seen patients really respond quite well to this treatment. It's much more comfortable than Procera, which is cryopreserved amniotic membrane mounted on a contact lens. And it's also a lot easier to stock in the clinic. The benefits of lateral Pterosaur Fee should not be underestimated. I typically perform a permanent Pterosaur Fee in these patients because of the chronicity of the disease. That means that I debride the epithelium of the lid margin, both upper and lower, so that when I do my Pterosaur Fee, the lids actually heal together. I then can slowly open up the tarsus in steps and see if the patient tolerates the amount of opening of the lid. This is one of my patients where I've opened the majority of the Pterosaur Fee, and you can see that the patient is starting to get some epitheliopathy again, so I definitely would not open this tarsus any further. Scleral lenses have really changed the practice of cornea in many ways, and they can be used for many ocular surface diseases. And as you know, scleral lenses really vault over the cornea, resting on the sclera and providing a reservoir of fluid to bathe the cornea. And I use them to treat chronic epithelial defects. And particularly if the patient has exposure that we can't deal with, we can even ask the patient to purchase 2 sets. Of course, that is quite expensive, but they can use 1 set during the day, and then while that set is being cleaned, they can use another one during the night. I usually, if patients have a chronic epithelial defect, I usually have them put a drop of Vigamox into the reservoir and to prevent them from getting an infection, but I have seen that really promote epithelial healing. And you can see the pictures from Alan Kwok at Boston site in treatment of a patient with filamentary keratitis with Boston Prose device, really healed the ocular surface. One of the most exciting innovations is topical recombinant human growth factor, Synagermin, which is FDA approved for the treatment of neurotrophic keratitis. This is the US trial, which was conducted at 11 sites, and they randomized patients with stage 2 or 3 neurotrophic keratitis to topical Synagermin, 20 micrograms per milliliter versus vehicle, 6 times a day for 8 weeks. And the primary outcome was ocular healing. They defined that as they defined it in 2 different ways, actually. The first was that the patient would have an ocular staining lesion, a corneal staining lesion less than 5 millimeters, 0.5 millimeters, excuse me, or 0 millimeter lesion staining. And you can see that at 8 weeks, those randomized to Synagermin had a statistically significant improvement in corneal healing compared with vehicle. Finally, I'll talk a little bit about corneal neurotization, which is a much more extensive treatment. Nerve grafts are harvested from the sural nerve or the great auricular nerve, and the grafted to the contralateral supratrochlear or supraorbital nerve. The graft is then brought to the eye with neurotrophic keratitis. The components of the nerve graft are separated and inserted into the perilumbal cornea. And patients experience subjective improvement pretty quickly. Objective measures of corneal sensation may take a little bit longer, but this procedure has been shown to promote healing of the epithelium. This is a confocal study of a patient after corneal neurotization surgery. And you can see at 3, 6, and 12 months, there's progressive restoration of the corneal nerve plexus. It's unclear why this happens. It may be from direct nerve sprouting from these perilumbal nerves, but that has not been confirmed. Probably more likely, the graft provides endoneural support to allow regeneration. So in conclusion, neurotrophic keratitis is a very difficult condition to treat. However, there are a number of novel treatments that are allowing us to offer more hope for our patients who are suffering with this condition. Thank you so much for your time.